often talk about external systems, economics, technology, the environment, but today we are turning the lens inward.
Way in.
We're going to talk about something that is, I would argue, one of the most universal human experiences, and yet somehow we are all still incredibly awkward talking about it.
It's the great equalizer, isn't it? But it's also one of the most misunderstood systems in the entire human body.
Absolutely. We're talking about the plumbing. Specifically, when the plumbing stops working, we're doing a deep dive into constipation. And before you reach for the skip button, because you know the drill, eat more fiber, drink more water. Let me stop you right there. The research we have in front of us today is vastly more interesting than just, a lecture on eating bran muffins.
It really is. I mean, when you actually dig into the clinical literature, you start to realize this isn't just about diet. It's about neurology, it's about physics, and it's about pharmacology. It is, at its core, a complex engineering problem.
That is exactly the tone we want to set. Our mission today is to move way past the basic advice you find on the back of the cereal box. We're going to look at biology, the surprisingly rigid definitions of what even counts as a problem.
Which is fascinating in itself.
It is. We'll get into the weird hierarchy of treatments and honestly, the surprising things that might be causing it that have absolutely nothing to do with what you ate for lunch. We've got a stack of clinical literature here, including detailed pathophysiology and some pretty intense pharmacological breakdowns.
It is surprisingly technical. And I think approaching it like engineers looking at a hydraulic system is the best way to strip away some of that embarrassment. Because, essentially that is what you're getting, is a high-pressure hydraulic system designed for water reclamation and waste processing.
Okay, so let's start there. Let's define the parameters. Because constipation is a word people throw around so loosely. You hear people say, oh, I haven't gone since yesterday morning, I'm so constipated. But medically, does that actually count?
Often, no. And this is really where the disconnect lies, between the patient's experience and the doctor's actual diagnosis. The American Gastroenterological Association, they have very specific metrics.
Okay.
And they focus less on the calendar and much more on the mechanics.
Right. The source material highlights that it isn't just about frequency, it's about the quality of the experience, which is a phrase I never thought I'd use in this context, but here we are.
Quality of the experience is the perfect, polite medical way of asking, was it successful? Did the system work as intended? The clinical definition includes difficult or infrequent passage of stool, yes.
Sure, that's the obvious part.
But also hardness, the need for excessive straining, or, and this is a really critical one, a feeling of incomplete defecation.
That sensation that the job isn't done, that you're not finished.
Exactly. You could effectively go every single day. But if you are straining significantly or if you consistently feel blocked afterwards, you actually meet the clinical criteria for constipation. It's not just a numbers game.
Although, speaking of numbers, there are some really specific benchmarks in the source that surprised me, specifically regarding gender differences.
This is a fascinating bit of biology. It really is. The literature notes that what we consider a normal frequency varies by biological sex.
Okay, how so?
Well, for women, the threshold for diagnosing constipation is typically fewer than 3 stools per week.
Fewer than 3, okay.
But for men, it's fewer than 5.
Wait. That's a huge difference. Fewer than 3 versus fewer than 5. What does that tell us about the underlying system? Why is it so different?
It implies a fundamental difference in what's called colonic transit time. So basically, the motility, how fast things move through the pipe. Men, on average, just have faster transit times.
The machinery runs at a different cadence.
A different cadence, that's a great way to put it. So a frequency that is perfectly healthy and normal for a woman might actually indicate a slowdown for a man.
And then there are the other diagnostic numbers. The text says if you are straining more than 25% of the time, that's clinically significant.
Right. And just think about that. 1 out of every 4 times. That's a huge amount of effort. And then there's what I call the 3-day rule.
The 3-day rule.
If you go more than 3 consecutive days without a bowel movement, that is the universal red line. That's when doctors really start paying attention, regardless of your other symptoms.
Why 3 days? What's the magic behind that number? What's happening in there?
It all goes back to how the colon functions. Its primary job isn't just to move waste out. Its main job is to reabsorb water. It takes this liquid slurry from the small intestine and it dehydrates it to form solid stool. It's a drying machine.
So the longer the waste sits in that machine,
the more water gets pulled out.
So it becomes a self-fulfilling cycle, a downward spiral.
Precisely. It sits, so it dries out. Then it becomes harder, almost like a rock, which makes it physically harder to push, so it sits even longer and it dries out even more. Breaking that cycle is the entire core of treatment.
Okay, so we have the definition down. Now let's get into the why. And this is where the expert source makes a really crucial distinction that I think most of us, myself included, miss. Constipation is not a disease.
No, it's not. And that is probably the most important mindset shift you can make when thinking about this. If you have a fever, the fever isn't the disease, right?
Right, it's a symptom of something else. An infection.
It's your body reacting to an infection. Constipation is exactly the same. It is a signal. It's a light on the dashboard telling you something is wrong.
The text breaks this down into primary and secondary constipation. Let's unpack that a little.
So primary constipation is when the issue is, intrinsic to the gut itself. It's just a slow transit time. Maybe the muscles are a bit lazy or the pelvic floor isn't coordinating properly. There's no external villain. The gut itself is just underperforming.
But secondary constipation, that's where the real detective work begins.
That's it. Secondary means the constipation is the result of something else entirely. It could be drugs, it could be your lifestyle, or it could be other underlying medical disorders. And the list of medical disorders that can trigger this it's wild.
We expect the GI stuff, right? The source lists irritable bowel syndrome, diverticulitis, hemorrhoids. That all makes sense. If the pipe is broken or inflamed, of course the flow stops.
Sure. And things like tumors, hernias, or even something called a volvulus, which is a literal twisting of the bowel loop. Those are obvious mechanical blockages. But what's really fascinating is the systemic stuff, the things happening elsewhere in your body.
The metabolic list completely blew my mind. Diabetes is a major cause.
A huge cause.
Yeah.
Specifically, diabetes with neuropathy. We tend to think of diabetes affecting the nerves in the feet or the eyes, but high blood sugar over time destroys nerves everywhere.
Everywhere.
Everywhere. And that includes the autonomic nervous system. That's the automatic wiring that tells your internal organs what to do without you thinking about it.
So the nerves that are supposed to tell the colon to squeeze, to contract, they just burn out.
Essentially, yes. This is called diabetic gastroparesis, or more broadly, enteropathy, the signal to perform peristalsis, that wave-like contraction that pushes things along. It just doesn't get through reliably. So the patient thinks they need more fiber, but what they really have is a wiring problem.
It also lists hypothyroidism.
Yeah, think of the thyroid as the master idle screw for your entire body's metabolism.
This idle screw, I like that.
If you have hypothyroidism, your idle is set too low. Everything slows down. Your heart rate, your cognition, your energy levels, and yes, your digestion. It's a classic sign of low thyroid function.
And then there's the neurological category. This is even more surprising. Parkinson's disease, spinal cord injuries, even head trauma.
Because defecation is a complex, coordinated event. It's not just gravity. It requires the brain, the spinal cord, and the bowel to all talk to each other in perfect harmony.
A converse.
A very important one. And if those neural pathways are damaged, like in a spinal cord injury or a stroke, which the text refers to as cerebrospinal accidents, the coordination is lost. The brain might be saying go, but the message never arrives at the destination, or it gets garbled.
It really just highlights how connected the gut is to absolutely everything. It's not an island, but there is one category of secondary causes that I think is the most actionable for our listeners, and that is iatrogenic.
Which is a fancy way of saying doctor-caused, or more accurately, treatment-caused.
Drug-induced constipation. The text says this is a massive factor, and the biggest villain here seems to be opiates.
Without a doubt. Opiates are incredible at killing pain, but they're equally incredible at paralyzing the gut. It's their most common side effect.
How do they do that?
They bind to what are called mu-opioid receptors, which are all over your intestines, and when they bind to them, they essentially put the muscles into a coma. They just stop contracting. But here's a nuance from the source that I found really fascinating. The route of administration matters.
Right, I saw that. It says orally administered opiates like codeine pills often have a greater inhibitory effect on the gut than, say, an injected version like morphine.
Which seems totally counterintuitive, right? You'd think the drug is the drug. But when you swallow a pill, it has a direct local effect on the GI tract tissues before it even gets fully absorbed into the bloodstream.
So it hits the gut receptors first and hardest.
First and hardest. The text specifically calls out codeine as a potent anti-motility agent. It's very good at stopping things up.
So taking a pill for your back pain might actually be worse for your plumbing than getting a shot of morphine in the hospital. That's wild. But it's not just painkillers. The list of offenders is so long. Antihistamines. my allergy medicine.
Yes. And this brings us back to the mechanism. Many common antihistamines have what are called anticholinergic properties. Acetylcholine is a key neurotransmitter that drives muscle contraction in the gut. It's the go chemical.
Okay.
Antihistamines block acetylcholine to stop your nose from running and your eyes from watering.
But they also dry up the movement of the bowel at the same time.
Exactly. You are systematically turning off the body's moisture and movement signals. It's a systemic effect.
Tricyclic antidepressants are on the list, too. And calcium channel blockers for heart issues.
That's basic physiology coming back to bite us. To make any muscle in your body contract, calcium has to flow into the cells. Calcium channel blockers work by stopping that flow to the blood vessels in the heart, which forces them to relax and lowers blood pressure.
Which is great for your heart.
Great for your heart, but your colon is also a muscle. A very large, very important muscle.
So you relax the heart, you accidentally relax the colon.
And suddenly nothing is moving. You've solved one problem and created a new one.
And here's one that I bet catches so many people off guard. Iron supplements.
Oh, iron preparations are notorious for this. People take them for anemia, which is very important, but they often aren't warned that iron is incredibly constipating. It's known to turn the stool black and hard as a rock.
And antacids, the very thing you take for stomach upset. Specifically the ones with calcium carbonate or aluminum hydroxide.
Which is deeply ironic because people often take antacids for stomach upset, which might actually be the early signs of constipation, like bloating or gas. So they take the antacid to feel better.
And they end up basically cementing the problem.
Literally. They make it much, much worse.
Wow. It really makes you want to go and check your entire medicine cabinet. So we know the causes. Now let's talk about what it looks like clinically. Obviously, we know the can't-go part. But the source mentions the incredible importance of history taking.
Right. A good doctor isn't just going to ask, how often are you going? They are going to hunt for the alarm signs. Because, 90% of the time, constipation is just annoying. It's a quality of life issue. But 10% of the time, it's a siren.
The red flags, these are the things that tell you this isn't just a lack of fiber, this is potentially an emergency.
Exactly. The first and most obvious one is blood. But even the type of blood tells a story. You have what's called hematochezia.
Hematochezia.
That's bright red blood. That usually means the bleeding is happening near the exit. So things like hemorrhoids or an anal fissure. It's alarming, but usually less medically urgent. But then you have melena.
Which is the dark stuff.
Dark, sticky, tar-like stool. It has a very specific foul odor. That is digested blood.
Digested blood?
Which implies the bleeding is happening much higher up in the digestive tract, like a stomach ulcer or, more worryingly, a tumor in the upper colon. That is a major emergency signal.
Other alarms listed here include unintentional weight loss.
Yes. If you are losing weight without trying and you are constipated, that is a classic sign of a potential malignancy. A tumor might be physically blocking the passage while also consuming your body's energy and resources. Also, anorexia, which in this context means a total loss of appetite and nausea or vomiting.
And age is a massive factor here, isn't it?
Huge. It's the age 50 rule. If a 20-year-old gets constipated, it's probably their diet or medication. But if someone is over the age of 50 and suddenly develops new-onset constipation when they've been regular their whole life, that is a big red flag.
Why?
Because it suggests a new obstruction has appeared. Something has changed in the structure of the colon, and that could be a mass or a tumor.
The source says if you have any of these alarm signals, you don't mess around with supplements or diet changes, you go straight to diagnostics.
Right. No messing around. You're looking at a colonoscopy, a sigmoidoscopy, or a barium enema. They need to physically visualize the structure of the colon to see what's going on.
But interestingly, for standard cases without these alarms, the text says routine laboratory tests, like blood work, aren't usually recommended.
That's right. They're not usually recommended unless they suspect a specific organic disorder, like the thyroid issue we mentioned. In that case, they check your thyroid levels.
So they aren't going to run a full blood panel just because you're backed up for a few days.
Usually not. It's not cost-effective or necessary unless the history points to a specific systemic disease.
Okay, that makes sense. Let's pivot to the solution side of things. The treatment hierarchy. I love a good hierarchy. It feels very orderly and logical.
It is the logical way to approach medicine. You always start with the least invasive, safest interventions, and you only escalate as needed. You climb the ladder one rung at a time.
Phase 1. Lifestyle. The text lists the goals here pretty clearly. Relieve symptoms, reestablish normal habits, and of course, improve quality of life. And the first line of defense is, naturally. diet.
To the surprise of absolutely no one. But we need to be very specific here. We aren't just saying eat a salad. We're talking about a clear target, 20 to 25 grams of fiber daily.
Which is actually a lot more than you'd think if you're eating a standard Western diet.
It's a significant amount. Sources like fruits, vegetables, and whole grain cereals are key. But, and this is a big but that the source highlights, there is a startup cost to this strategy.
The startup cost. I love that term. It sounds like something from economics, but it feels a lot more like bloating.
That's exactly what it is. If you go from a 5-gram-a-day fiber diet to a 25-gram diet with a lot of bran overnight, you are going to be miserable. The source explicitly warns of abdominal distension and flatus.
Gas.
A lot of gas. The bacteria in your gut, your microbiome, they go into a feeding frenzy and all that new fiber. They ferment it, and the byproduct of that fermentation is gas.
So the advice is to ramp up very slowly.
Very slowly. And be patient. This is crucial. The text says a trial of dietary modification should last for at least 1 month.
1 month. That long.
That's so important. Most people try for 3 or 4 days, they get bloated, they feel uncomfortable, and they quit, saying fiber doesn't work for me. But the source notes that while you might see some effects in 3 to 5 days, it takes about a month to really reset the system and for your microbiome to adjust to the new normal.
Then there's the behavioral stuff. This sounds so simple, but the source really emphasizes responding to the urge to defecate.
This brings us to a physiological process called the gastrocolic reflex.
Okay.
When you eat a meal, especially a large one, your stomach stretches. That stretching sends a nerve signal all the way down to your colon, saying, essentially, incoming. Clear the decks. Make room.
And that triggers a contraction.
It causes a wave of contraction.
Yeah.
And for most people, this is strongest in the morning after breakfast. But what do? We ignore it. We're rushing to get the kids to school, we're on a Zoom call, we're in traffic.
And that's dangerous.
It's very dangerous in the long term. If you suppress that urge consistently, day after day, eventually the rectum stops signaling as effectively. The nerves become less sensitive. You can literally train your body to be constipated.
So rule number 1, when you gotta go, you gotta go. Don't put it off.
And try to establish a regular time. Your body loves routine. Train your bowel like you would train for any other physical activity.
Okay, so you've eaten the bread, you're drinking the water, you're responding to the urge, and still nothing is happening. It's time for phase 2.
Pharmacology.
The world of laxatives. This section of the source was so incredibly helpful because it breaks them down not just by their chemical type, but by their speed. It's like a menu. How fast do you need relief?
Exactly. It's the most practical way to think about it. It helps you categorize them by their mechanism and their onset of action.
So category 1, these are the slow movers. The text says they take 1 to 3 days to work.
These are your softening agents.
Yeah.
This group includes your bulk-forming agents like methylcellulose, psyllium, which is Metamucil, and polycarbophil. These are really just extensions of the dietary strategy.
How do they work?
They're basically indigestible fibers that absorb a lot of water in the gut. They swell up into a soft gel, and that gel-like mass mechanically stretches the bowel wall, which is the natural trigger for peristalsis.
Also in this 1 to 3 day category are the emollients or the docusets.
Docusate sodium or calcium, you'd know them as colas. These are surfactants. Essentially, they're soaps.
Soups.
Yeah, they lower the surface tension of the stool. This allows water and lipids or fats to penetrate it, which makes it softer.
But here is the aha moment for me from the text. The expert note says these aren't actually that great for treating active existing constipation.
Correct. I like to say they're all mush, no push. If you were already backed up with a hard, impacted mass, Docusate usually isn't strong enough to move it out. It just makes the front of it a bit softer.
So what are they good for?
They are excellent for prevention, specifically for preventing straining.
The source specifically calls out patients who've just had a heart attack.
Right. If you just had a myocardial infarction, the absolute last thing you want to do is the Valsalva maneuver. Bearing down, holding your breath, face turning red.
Right.
That action spikes your blood pressure and puts immense stress on the heart. So they put these patients on DocuSeats to ensure everything just slides out without any effort. It's a safety measure.
Same for after rectal surgery, it says, where you don't want to tear any stitches.
Exactly. It's a really important distinction. Prevention versus cure.
Okay. Also in the slow category, we have lactulose and sorbitol.
These are what we call osmotic laxatives. They're sugars that your body doesn't absorb well. So they sit in the gut, and through osmosis, they pull water in.
And the source throws some serious shade at lactulose here.
It does. It's very clear. It notes that lactulose is costly and causes a lot of gas and bloating because it ferments very rapidly in the colon.
Whereas sorbitol.
Sorbitol is a monosaccharide, a simpler sugar. The text says it works just as well. It causes less nausea, and it is much, much cheaper. It's explicitly recommended for elderly patients or those who are cognitively intact. It's a very practical, often underutilized option.
Okay, so that's the slow lane, 1 to 3 days. Now we need to speed things up a bit. Category 2, a soft or semi-fluid stool in 6 to 12 hours.
Right, now we're getting into the stimulants. This is your bicycodil, like Dulcolax and Senna.
How do these work differently from the first category? They're not just bulking or softening.
No. Instead of just passively bulking up the stool or wetting it, these drugs chemically irritate the lining of the bowel. They directly stimulate the nerves in the intestinal wall.
So they are actively forcing the push.
Yes. They force the muscles to contract. They create propulsive waves. Magnesium sulfate, or Epsom salt, in low doses also fits into this category. This is typically what you'd take before bed to produce a reliable movement the next morning.
Okay. But let's say it's an emergency. You need, and I'm quoting the text here, watery evacuation in 1 to 6 hours. This is category 3.
These are the big guns. These are for when you need to clean the system out and fast. This includes the saline cathartics, things like magnesium citrate, milk of magnesia, which is magnesium hydroxide, and sodium phosphates, like in a fleet enema.
And PEG, polyethylene glycol.
PEG is fascinating because it's all about the dose. At low doses, 17 to 34 grams, it's a gentle daily maintenance osmotic laxative. That's what you buy over the counter as Miralax.
Right.
But at high doses, and we're talking 4 liters of solution, it is used for whole bowel irrigation.
That's the colonoscopy prep stuff that clears you out completely.
Exactly. It leaves the pipe sparkling. Chrome finish, as they say in gastroenterology.
The mechanism for these category 3 drugs is, it's intense. It says they use poorly absorbed ions. What does that mean?
Okay, so your gut can't absorb ions like magnesium, sulfate, or citrate into the bloodstream very well. So they stay inside the intestine. Now, nature demands equilibrium osmotic balance.
Okay.
So to dilute this now very high concentration of ions inside your gut, water rushes out of your body tissues and into your gut.
It's osmosis in action.
Massive, powerful osmosis. The volume of fluid in the gut increases rapidly and dramatically, which triggers massive distension and a very rapid, forceful evacuation.
Hence the very strong warning in the text. These are for acute evacuation, like after a poisoning or for a medical exam. They are not for routine daily maintenance.
No, absolutely not.
Yeah.
You can seriously throw off your body's electrolytes and fluid balance. You are literally pulling water out of your body. If you use something like magnesium citrate every day, you're going to get dehydrated and potentially cause serious problems with your kidney function.
Okay, let's move on to section 5. Special agents and specific scenarios. There are some really specific and frankly scary warnings in the source material here. Let's talk about mineral oil.
Mineral oil. It's a classic lubricant laxative. It does exactly what it sounds like. It coats the stool in the inside of the intestine to make things slippery. Been around forever.
But the text has a very, very stern warning. Do not give this to bedridden patients. Why not?
Aspiration. It's a huge risk. If a bedridden or frail patient has any kind of reflux and they accidentally inhale even a tiny droplet of mineral oil into their lungs, the lungs cannot clear it. It's a foreign body. It causes something called lipoid pneumonia.
Lipoid pneumonia? That sounds absolutely terrible.
It is. It's a severe chronic inflammation of the lungs caused by the presence of fat or oil. It's very difficult to treat and can be fatal. Also, the source notes that if you use mineral oil too much, some of it can be absorbed systemically and cause foreign body reactions in your lymph nodes.
Yikes. Okay, so maybe skip the mineral oil if there are other safer options available. What about for kids? The source mentions glycerin.
Glycerin suppositories. These are considered very safe and are a go-to for pediatric constipation. They work in 2 ways. By rectal osmosis, so pulling a little water into the very end of the rectum, and by causing a mild irritation that stimulates a contraction. They usually work in less than 30 minutes.
Yeah, what about the high-tech stuff? The source mentions some newer agents like lubiprostone, which is sold as Amitiza, and linaclotide, or Linzess.
These are really exciting because they represent a new way of thinking. Instead of just irritating the gut or filling it with fiber, these drugs work on specific ion channels in the cells of the gut lining. Lubiprostone, for example, activates chloride channels.
Chloride channels, how does that help?
Well, when you open those channels, chloride ions are actively pumped out of the cells and into the intestine. And water always follows salt, so water follows the chloride. You are actively pumping fluid into the gut to soften the stool and accelerate its transit. It's what's called a secretagogue.
And these are approved for chronic idiopathic constipation and IBS.
Yes. These are for people where the fiber and the simple over-the-counter laxatives just aren't cutting it for their long-term chronic problem. Linaclotide is similar, but works on a different target called guanylate cyclase C. It's important to note the age restriction there, though. Linaclotide should not be used in patients under 18.
We talked earlier about how opioids cause constipation. The source mentions a really clever class of drugs to combat this called opioid receptor antagonists.
This is pharmacology at its absolute finest. So you have a patient in severe pain, maybe they have terminal cancer or they're post-surgery, and they need morphine to function. But the morphine is stopping their gut completely.
Right.
Now, if you give them a standard opioid blocker like naloxone, Narcan, you will stop the gut issue, yes, but you'll also block the morphine in their brain.
Which means their pain comes roaring back. A terrible trade-off.
An unacceptable one. So scientists developed these brilliant drugs like alvemopan and methylnaltrexone. These are peripherally acting antagonists. They are large, charged molecules that physically cannot cross the blood-brain barrier.
So they are blocked from ever entering the brain.
Exactly. But they can circulate throughout the rest of the body, so they go to the gut and they block the opioid receptors there, waking the bowel up, but they never touch the pain relief receptors in the brain. The patient stays pain-free, but they can finally have a bowel movement.
That is absolutely brilliant. The text mentions alvemopan is specifically used for hospitalized patients after bowel resection surgery to get things moving again faster.
It's been a game changer for postoperative recovery times.
Okay, last one. Let's talk enemas. The classic tap water enema.
Simple, cheap, and effective. About 200 milliliters of plain water usually works within an hour and a half. It softens the stool at the end of the line, and the volume distends the rectum, triggering a contraction.
But the source has a very specific do not use warning for a type of enema that used to be common, soap suds.
Yeah, this was an old-school nursing remedy. The idea was to put a little bit of soap in the enema water to irritate the bowel and make it contract more forcefully. The text explicitly says this is no longer recommended at all.
Because it causes colitis.
It causes proctitis, which is inflammation of the rectum and colitis. Soap is a harsh chemical detergent. It damages the delicate mucosal lining of the colon. It's far too aggressive. Stick to plain tap water or the prepackaged saline ones.
Okay, we have covered a lot of ground. I mean, from the clinical definition of straining to the perils of mineral oil aspiration. Let's try to bring this all home.
I think if we summarize the whole approach, it's a ladder. You always start at the bottom rung. First, check your lifestyle, check your diet. Are you honestly getting that 20 to 25 grams of fiber? Are you actually drinking enough water? Are you listening to your body when it says it's time to go?
And if that fails, then you move up to the bulk formers, the psyllium, methylcellulose.
Exactly. And before you even think about reaching for the heavy-duty stimulant laxatives, you have to ask the why question again. You have to look at your medication list. Are you taking iron? Are you taking a daily antihistamine? Did you just start an opiate for a bad back?
Because if you don't fix the root cause, that secondary cause, you're just fighting an uphill battle you can't win.
Precisely. You're just treating a symptom while ignoring the disease. And of course, remember those alarm signs. Any blood, any unintentional weight loss, any sudden changes after age 50, those require a doctor, not a trip to the drugstore.
It really makes you appreciate the complexity of the body. You think of digestion as the simple automatic thing, but it's this delicate balance of neurology, chemistry, hydraulics, and mechanics. And one little pill, or just a lack of water, can bring the whole factory to a grinding halt.
It is a constant feedback loop. And constipation is often your body's way of telling you that one of your fundamental inputs, be it hydration, nutrition, or medication, is off balance. It's a dashboard warning light. Don't just put a piece of tape over it and ignore it.
So, a final thought for our listeners. Next time you're feeling blocked up, don't just be annoyed. Be a detective. Look at the inputs. Review the system. And maybe, just maybe, check your medicine cabinet.
And check your own personal definition of normal. You might find out that you are perfectly healthy and just happen to be on a different schedule than the person next to you. And that's okay.
That is going to be our final thought for today. Verify you're normal. Thanks for diving deep with us into the plumbing.
Stay regular, everyone.
See you next time.